So I'm going to kick us off here. I'm Veronica Gonzalez. I'm the CEO of Valley Health Partners Community Health Center, and so I'll speak a little bit more about us in just a bit. I'm going to kick us off on behalf of my community health center peers and introduce what is a federally qualified health center, or an FQHC. They're also known as community health centers. They've been around since the 1960s and were a part of President Johnson's War on Poverty movement. That is a movement that continues until this very day as FQHCs continue in their journey to achieve health equity in the communities they serve. So there are over 1,400 health centers across the nation, 3 here in the Lehigh Valley, as Erica mentioned, and you'll get to know more about them this afternoon. We are nonprofit organizations offering primary care and preventative healthcare services, and we are federally supported by Health Resources and Services Administration. So HRSA is our federal governing body. They do have specific federal program requirements that we have to abide by, and I'll share a little bit more about that today. We are mission driven. We take care of the most vulnerable populations, and we provide whole person care, right? Regardless of the patient's ability to pay. And what that means is that we manage both medical needs as well as the social determinants of health. Community health centers are known to go beyond the traditional 4 walls of medicine and really address those root causes of poor health. So we focus on value and prevention and really operate with a health equity lens. So we understand the communities we serve often have a language barrier, cultural barriers, socioeconomic barriers. And when we think about new programs and services, we really want to be centered where our patients are and meet them where they are. We are eligible for an enhanced Medicaid and Medicare reimbursement rate from the state that really allows us to provide those wraparound support services. And we also have many health centers are grantees in our space, Neighborhood Health Centers of the Lehigh Valley. They're a grantee and they receive their annual federal grant funding. You'll hear the term FQHC lookalike, which Star Community Health and both Valley Health Partners are FQHC lookalikes because we are not grantees. And so you'll learn more about that as well. We're all located in areas of high need, and what that means is we are in areas that are designated by the federal government as medically underserved. And then one of the very unique components of an FQHC is that they're community driven and community led. So one of the HRSA program requirements is that all FQHCs must be governed by majority consumer board members. So those are patients who receive care within your 4 walls and represent the community you serve. So really making sure that all strategic decision-making of the health center is aligned with the needs of the population you serve. And so these are the specific program requirements of any community health center. There is a compliance manual HRSA provides. I won't bore you with the details, but I'll point out at the end the governance section, right? So one of the requirements of a community health center is that you cannot be owned or controlled or operated by another entity. And so the federal program HRSA wants to make sure that any enhanced reimbursement you're receiving, federal dollars you're receiving, really goes back to the community you serve and not to a health system at large, for example. So us at Valley Health Partners, we are a spinoff from well-established community-based practices that were previously under Lehigh Valley Health Network for over 3 decades. However, now we're a separate entity. While we're proud of our roots and being strong partners of LVHN, we're not a subsidiary. We are separate and distinct as a health center. And then these are just some high-level stats of community health centers across the nation. As of 2021, they served over 30 million patients. And you can see there are over 14,000 locations across the country. And you can see the breakdown of the population served, primarily those who are uninsured, publicly insured, of low income, members of racial and ethnic minority groups, and a lot of special populations served by community health centers. So our nation's veterans, those suffering from homelessness, those suffering from substance use disorder. We really are the safety net across the nation for healthcare services. And through the pandemic, the federal government really called out to community health centers, right, to support and meet patients where they are, recognizing that disproportionate impact COVID-19 had on these communities, because health centers really are led by the community, know how to build a trust, and are accessible to vulnerable populations. Before I jump to introduce Valley Health Partners, any questions I can answer, or Melissa, if Mark is on, anything you guys want to add about community health centers?
You guys did a good job.
Okay.
No, we're solid. Mark is actually here in my office. He was having some computer trouble, so he is logged in here with me.
Oh, perfect. All right. Welcome, Mark.
Veronica,
Yes.
it mentions they are look-alike organizations. Do we have look-alike organizations in our area?
Yeah, so Valley Health Partners Community Health Center and Star Community Health are both FQHC lookalikes. And so we're both spin-offs from the two local large health systems, Valley Health Partners from LVHN, Star Community Health from St. Luke's. And then Neighborhood Health Centers of the Lehigh Valley, which is the original FQHC, they are a grantee. So they are an FQHC. We both follow the same program requirements, but to be a grantee, it is a competitive process and you have to wait until the federal government actually provides the potential for grants. There haven't been an opportunity in the last 3 years, so we're all patiently waiting. It's certainly a goal of both STAR and Valley Health Partners, but right now we are considered lookalikes. All right, so I'm going to introduce Valley Health Partners Community Health Center. We opened doors July 1st of 2020. However, we officially became designated as an FQHC lookalike on September 1st of 2021. It is an extensive process. You know, HRSA does require you to operate in compliance with their program requirements for 6 months before you can even submit your application to be considered as an FQHC lookalike. And so that journey for us took some time through the pandemic, and then we successfully achieved designation in 2021. And so these are the practices and programs that transitioned from Lehigh Valley Health Network to Valley Health Partners as of July 1st of 2020. I'll share a little bit more about them in the presentation. And then some of the new sites we opened up since our inception, which include an additional school-based health center, Vision, Cairo. And very exciting news for us, an expansion happening this summer in downtown Allentown. This is the previous Morning Call Administration building. So we're partnering with Community Services for Children. If you're familiar with them, they focus on early childhood education, and they will be opening up 20 additional classrooms on the first and second floor, increasing access to over 400 children in our community to have high quality early childhood education. Recognizing in our community, Allentown does have one of the poorest performing school districts in the state. Many of our children are not reading at 3rd grade level, subsequently not graduating from high school. And so really that focus on early childhood education is a big gap in our community. And then the 3rd floor will be healthcare. And so we'll be expanding pediatric primary care, pediatric dentistry, as well as vision for kids and adults on the 3rd floor. Oops, sorry, wrong way. All right, so our mission vision, I won't read this for you. We'll share the slides, but really our North obviously is our focus on health equity being led by the people in our community. And we're really proud of our culture that's very family centered and culturally sensitive. And so I'll share a quick mission moment story here. This is Gloria Rivera. She's a community health worker at VHP. And this is a quick story of a longstanding diabetic patient at one of our adult internal medicine clinics where her diabetes was unregulated. Doctor knew she was an engaged patient, couldn't understand what was happening. And so Gloria went out to the patient's home and found out that her refrigerator wasn't working well. And that's why her insulin wasn't working. So through Gloria's connections, she was able to get the patient a new refrigerator, right? Getting her insulin to work, some fresh and healthy food. And so when we talk about community health centers going beyond the traditional 4 walls of medicine, right? This is what we do is we understand this is a patient who has a language barrier, low health literacy, socioeconomic barriers, and just was frustrated with, you know, she wasn't feeling well and we just couldn't get down to the root cause. A little bit about the demographics we serve. Valley Health Partners is primarily in the Allentown area, so large Hispanic Latino community, and you can see the breakdown of ethnicity, race, and language. And about 38,000 patients we serve. And then one of the things we're really proud of is we do have a coordinated approach to care. And so I'm sure you're all familiar with social determinants of health. We do have a standardized social screener across our health center. So all of the families who walk into our 4 walls, we're screening them for social determinants of health. And then we have a multidisciplinary group of professionals that really can meet our patients where they are and eliminate some of those barriers to care, such as Gloria, right, our community health worker. And we can't do that on our own. It takes a village. And that's the beauty of community health centers. It's all about collaboration. And so we work with our peer community health centers, many nonprofits in the community. We have over 100 partnerships through Allentown School District, government agencies, and community-based organizations. And then quick virtual tour. So we do have 3 primary care practices at Valley Health Partners, Centro de Salud Family Health Center, and LVPP, serving over 13,000 patients in the community. All of the clinics, again, have that multidisciplinary approach in the practice, providing whole person care. I'll quickly highlight Family Health Center. We do have integrated medication-assisted treatment. So we treat patients from substance use disorder that are suffering from substance use disorder in the primary care setting. So really removing the stigma and treating the disorder, right? No one knows why I'm at the primary care office. And that's been a great success since we started that program about 2 years ago. We also have a large diabetic population in our adult primary care practices. And so we do have embedded diabetic educators and care managers and really producing strong outcomes in diabetes. Women's health, we do take care of a lot of thousands of women on an annual basis. Lots of information here. Again, we'll share the slides. But what's really cool about Center for Women's Medicine, it is a one-stop shop. So for high-risk pregnant women who often have to go to multiple appointments, sometimes on a weekly basis, we do bring all the specialists to the clinic, including maternal fetal medicine, endocrinologists, psychiatrists. They come weekly. They take care of the women in-house. And we proactively manage their social barriers within the clinic as well. We do have a great incentive program. So that's an actual picture of our baby store there. It's a point-based program allowing our moms to accumulate points as they show up for their appointments and they shop at postpartum. Pediatrics is our largest service line at Valley Health Partners. So we do take care of over 18,000 children in our community, primarily in the Allentown area. And so we're very proud of this clinic. We have a lot of specialized programs based on the children we take care of, such as an ADHD clinic, asthma clinic, adolescent and complex care, as well as obesity clinic. And we do have a kitchen in our clinic. So we get to do some fun cooking classes with the children. And then we have 2 school-based health centers, one at Sheridan Elementary in the Allentown School District, and then the most recently built with the Allentown School District, Brigadier General Anna Mae Hayes Elementary. So you can see some pictures of our clinics there, as well as our lovely dedicated staff. And we do provide full primary care services at these locations. We also see any of the children at the school district that are not vaccinated, are not meeting their requirements to start school, and partner very closely with the school, again, meeting the children where they are. And then our street medicine program. So this is a very robust program. We're part of an international movement, really focused on providing healthcare to the homeless where they're most comfortable to receive care. So our team is providing primary care services. We have an attending 2 physician assistants out in the woods, under the bridge, different soup kitchens and shelters. We have multiple partnerships in the community, provide not just primary care, but also medication-assisted treatment for those suffering from substance use disorder, telepsychiatry. We also have a criminal justice navigator. This is a brand new role that is really supporting a specific population suffering from homelessness. And this team just does a really nice job at building that trust, right? And that philosophy of going to the people, and again, removing those barriers to care. And then vision and dental services. So when we stood up our health center, we looked at our needs assessment, right? What are the gaps in the communities we serve? And vision and dental really rose to the top. So the Allentown School District subsequently shared with us, you know, if they have to identify the needs in the children within the district, it's vision and dental. And so it's certainly aligned with our findings. And so that's why we are expanding pediatric dentistry, and we stood up our vision site, which will expand in the summer. We opened up our vision site in July, and I can tell you the level of acuity that we are seeing in those 4 walls really speaks to members of our community delaying care because they don't have accessible vision services, you know, within their geographic area. And then lastly, our Veterans Health Program at Valley Health Partners. So this is a group of folks, and you can see them there on the picture, that are really subject matter experts on veterans health. They provide navigation and coordination for our veteran community, guidance and care planning. They have very dedicated veteran-focused partnerships in the community. And this is a service that we offer not just to veterans within Valley Health Partners, but really veterans across the Lehigh Valley that are in need of those services. So lots of information there. I will share the slides, Erica, so we can pass them on, and certainly make myself available. But wanted to really just highlight Valley Health Partners, kind of our commitment to vulnerable populations here in the Lehigh Valley. Again, we are a spinoff from Lehigh Valley Health Network, and the beauty of that is that we partner collectively to serve the underserved. We're really the ambulatory home for vulnerable populations and have the resources, those wraparound services. We provide care that's culturally sensitive, linguistically appropriate. And the health system is really where we can send our patients for specialized care and more acute care support. So Mark, I think I'm passing it on to you. Yep,
Great.
we can hear you.
Excellent. Okay. So I want to take the time here and talk a little bit about Star Community Health. As Veronica mentioned, we are the other lookalike center here in the Valley. Our organization began in January of 2019. This is the beginning of our 4th year, and a very exciting year that we're embarking on, as we expect so much to really happen this year. I want to start with our vision, and like Veronica, I won't go through all the details, but I do want to say that we very keenly focus on quality, the quality of care that we provide to our patients. And I'll talk a little bit more about that later in the slides that I'm going to present to you. But diabetic programs are key, top of mind for us, and we have several programs going on, and it leads to a very low uncontrolled diabetic population that we serve. But again, more on that later. In terms of our size, we have 12 medical sites across Allentown, Bethlehem, and Easton, 3 additional dental sites, as well as 3 mobile vans that serve Allentown, Bethlehem, and further north as well. And so with that, it's over 41,000 patients, 41 that we serve, for over 150,000 visits per year. And those are stats from 2021. So we expect to exceed that considerably when reports are finished for the 2022 calendar year. We provide family medicine, internal medicine, pediatrics, women's health, and dental care services. But with that, we also find that our patients are less likely to go to specialist appointments when we refer them. And depending on the specialty, it could be as high as 50%. So we've brought in or embedded in our system 5 specialties, soon to be 7. And we, again, throughout this year, expect to exceed the 7 that we're planning to bring in, I guess, within the next few months. So that's a great benefit for our patients, particularly when we talk about the diabetic population and eye care and other things that they need. We, the center, have actually brought down our uncontrolled diabetic population to about 14%. That exceeds last year's goal and actual number for STAR by almost 10%. 14% is far less than the state average, than the national average as well. Just to give you a point of reference on that, last year, the average uncontrolled diabetic population for New Jersey was in the 40s, over 40%. So it's a great thing that we provide for that population.
I think we're 11% for 2020.
Thank you. And so Alicia just shared with me, Dr. Walty, that for this calendar year, we've brought the 14% uncontrolled rate down to 11%, which is fantastic. Our clinical teams, our residents, and so forth, I think currently there are at least 3 diabetic programs focused on reducing the care. And you can see in the slides that those efforts include so many different things, working with social workers and a tool that we have through Find Help, but it's also focusing on nutrition, exercise, and so forth. So it's a great thing that they do for the population. So I want to focus in on this slide. I want to focus in on the Find Help resource that we have. And this talks to our social determinants of health. So Find Help, and I'm guessing the other FQHCs, both other FQHCs have access to this resource as well. But it's a resource that actually provides financial assistance, access to food pantries, as well as housing assistance here in the Valley. So not only do we collect the data, but we take the next step in actually trying to close the gap and give the resources to the patients as they need them. So that's really, really important, because more so than just reporting the data to the state or the feds, that we actually close the gap. We actually give the patients the ability to go on to this site to find help, find the resources that they need, and follow up and actually close the gap that they have. All of the social determinants of health that you must be aware of actually are directly connected to and related to their health care. As Veronica mentioned a minute ago, it's not just enough to provide the medication. You have to take the next step to see if it's effective. So that was a very good story that she shared with us, with folks on her team. On to the next slide. So here you can see that we've received roughly $500,000 in grant funding last year. But beyond that grant funding, and all the grant funding obviously goes back into caring for the people and patients in our community. But beyond that, we all have access, all three of us have access to something called a 340B program. And that program is basically a pharmacy benefit program whereby we take, and I'll keep this super simple, but we take the funds that we have from that program and we distribute that back into the communities. So, for example, if there are folks that we treat in need of medical services, obviously there are, but if they can't afford those medical services, we use the 340B program or funds from that 340B program to help them. Also, there are patients who do not actually have access to the meds they need for dental care. Just last week, I got a call from one of our employees here for a patient who couldn't afford a dental medication, actually antibiotics, to start their dental care. And so we all know that if they don't have access to that, the problem becomes much more dire, and their healthcare just goes downhill, and they will end up likely in the emergency room for something that could be very simple. I actually drove out, picked up their medications, paid for them in the pharmacy so that the patient could actually walk to the pharmacy to pick them up themselves and actually proceed with their dental care. So the 340B program also supports transportation. It supports help for the uninsured, the underinsured, and as well as folks in need of SDOH, as I mentioned earlier. So all of our grant funding goes back into the community and makes a major difference. Should we have the opportunity to talk later or an additional session, I would drill down on that program to just inform or educate everyone as to the danger of that program going away, which would mean fewer services for the communities we serve, which would not be a good thing. As I mentioned earlier, our quality programs are top of mind for everyone in our organization. We roughly have, I think it's about 60 or 70 providers, and they focus heavily on our diabetic population. And you can see here in the slides, and I won't go through all the detail, but you can certainly read through them. We had efforts in this year and last year to reduce the rate of uncontrolled diabetics, and we did so. And at the third bullet, you can see here that we actually had a program whereby we wanted to increase the number of patients who received eye exams. And the challenge was 100 eye exams in 100 days. We actually exceeded that by 50%, over 50%. And we were excited to see that. So that was a great thing for the population as well. Here you can see where we score in terms of our quality programs, and we compared ourselves to other FQHCs, lookalikes, and statewide. So this is due to the teams that we have and the focus they have on quality, not just quantity. And it's a testament to all the great and hard work that they do as well. And our recognition, you can see here, to those quality programs are what we've received in 2020, actually 2022. So, and this is an ongoing program that HRSA has every year. And we have the Health Center Quality Leader Award. You can see here the efforts that we have addressing social risk factors and advancing HIT for quality. And so each one of these awards, well, I should say the two on the left. Advancing HIT for quality is basically having an EHR, using it to communicate with others involved, our partners involved in our patient care, other hospitals, other practices, and so forth. But the two on the left actually are a moving target. When I say that, these are measures that are determined by other centers across the nation. So you can't say that we're going to try to achieve 50% and exceed that. It really depends on how well others in the state and the nation do with these measures and what decile we end up in. And so for Quality Health Center, we have to be in the top 30%. So we exceeded that. So again, I can't stress enough how important the work we do for quality is, in addition to the quantity. We increase the number of patients that we see every year, but to decrease the level of chronic disease of the people that we see is more important than the total number of folks that we see. We have to make sure that folks get better, and our teams, our clinical teams, our administrative teams actually do a very good job at that. And so there's other information to share as well, but I just wanted to make sure I'm cognizant of time here. So with that, I will move forward and hand it off to Melissa Miranda. Thank you.
So welcome. Some of you may know me or not. I'm Melissa Miranda, previously known as Melissa Craig. I used to work way long time ago with Dr. Bonnie Foyle through St. Luke's Community Health, and have been working in the community health environment for 30 some years. We worked on the community health and FQHC, Federally Qualified Community Health Initiative, under St. Luke's. I kind of worked behind Bonnie in the early 2000s, and then moved over into NHCLV when Lisette Lajos was moving on. So I'm here to share a little bit about NHCLV and its development. Actually, its development dates way back. And so Veronica did share one of the primary healthcare or HRSA strategies or strategic priorities, right, is all about the model of care, improving outcomes. And that really is important. And I always stress it to everybody that we speak to, because like she said, it is supposed to be led by the community. And it's hard for people to conceptualize that. It's a different business model, because in essence, you are turning over that faith, that stewardship to the community. And you're saying the community knows best about what they need. And that's a hard thing to do. It's harder than many people would believe, but they really do know best. And it's not like it's a blind thing, right? Because one thing that we may have forgotten to mention is we have to do regular needs assessments. And that includes the community and our community partners. So it's not like we're doing it blindly. And just to kind of put it into context, our population here in the Valley has grown. So this is part of the needs assessment data that we are collecting. Actually, currently, we're in the middle of our needs assessment process. But our population does continue to grow. And so in the last 10 years, right, it's grown about 6%. So even an FQ like us, we have been growing organically, meaning we have been growing by virtue of the community. And so it is a slow growing process. And so it takes time to grow. And we have not grown commensurate with the population. So That is why we're benefiting from the lookalikes also. So just to give a brief timeline for NHCLV, it did take much longer than anybody, including the founding partners, expected. They kind of expected that they would establish the 501c3 and they would get recognized rather quickly. It did not happen. And in the midst of all that was Hurricane Katrina, as some may remember. So in 2009, they got recognized, but they didn't get any funding. And they didn't achieve that health center program grantee status as a full lookalike or with any subsidy until 2012. They definitely didn't expect 8 years to go by. That's for sure. I came on board in 2013 with one clinic, and that was the one located at Casa, the Vida Nueva clinic, where they had mushed everything into one health center site. Since then, we've grown, and that one center was located in the first ward. That's one medically underserved area. You can't just grow. As an FQHC, you have to grow within those designated medically underserved areas if you want to be able to apply and get what's called those subsidies or those grants. So when Veronica mentioned the new access point announcements, that's how you get either the designation or a subsidy to be able to help support the uninsured and underinsured population. Oops, what did I do here? Oh, so when I say it's a community led, it's a commitment of faith, time, and effort on everyone's part, and that different business model. It just is, because it doesn't function like a hospital. Our reimbursement's not like a hospital. Everything about it is different. We do get some benefits, and the lookalikes do benefit in the same way. In this way, except for number 4, right? So we all get cost-based reimbursement. What that means is all of the allowable costs are put all together, and then oops, hold on. I better plug in because I'm about to lose that. All of the costs are plugged in together, and then they basically say, well, how much does it actually cost you to help take care of this patient? Soup to nuts, social services, actual medical expenses, behavioral health, everything that qualifies, including interpretation services. How much does it actually cost? And then that's how much we're going to reimburse you for Medicaid and or some amount of it for Medicare, not private pay. Private pay is actually not one of our priority populations, right? Because we prioritize those living 200% of the federal poverty level or below. That's our priority population, or those uninsured. Okay. We do get medical liability protection, loan repayment, national health scholars, and or those that have loans by virtue of a medically underserved area, HEPSA, health professional shortage area designation. But if you have too many providers in an area, your score goes down. We do get that grant subsidy from the feds to help support the sliding fee scale that we have for uninsured people, because we are supposed to not have a barrier to care. And then those 340B pharmacy benefits. You might notice above that I wrote FQHC can actually benefit, but we have to apply for it. I say that because when I came on board, NHCLV had benefited from a grant from a foundation, and was being somewhat mentored. Unfortunately, they were still functioning almost like an outpatient clinic, so they hadn't applied for like Medicare Part A, and they hadn't credentialed their providers correctly, because they were still following recommendations that weren't necessarily correct. They hadn't applied for the medical liability, so they were still paying like medical liability insurance. And so they weren't getting reimbursed correctly. So the first year I got here, we had to apply for an EMR, and this is just an example. The first EMR we tried to get, the electronic medical record, they wouldn't partner with us because they thought that NHCLV was committing fraud. because they had billed $2 million, but only had gotten reimbursed for $122,000 because the EMR was being hosted on a different server and they couldn't work all the denials because they didn't have access to the medical record after it had been billed to work the denials. And the providers were not credentialed correctly because it wasn't credentialed as a type A, Medicare A eligible entity. Just a small, I mean, we took care of it rather quickly, but it's just an example of the entity. You have to accept the business model as being different. And well-intended individuals, if they don't understand that it is a different business model, can unintentionally sink the organization anyway. And then those 340B pharmacy benefits, again, if you don't apply for it and follow it and use them, you don't have them. And so we actually are only starting to actually benefit, unlike the lookalikes that have, they have the benefit of the hospital's experience and they're actually benefiting. NHCLV is only building that. So we're only now beginning to benefit from 340B pharmacy benefits because we're, if you will, a grassroots organization. And so we've only built the capacity to make sure that we have compliance with all of that. I like to think of us as more of like a snowman. So we're more bottom heavy, meaning we have more frontline staff and providers. So we more like our traditional nonprofit in terms of how much of administrative support we have to be able to build some of this stuff. So it's taken us a little bit longer, but we are benefiting. So the bulletin that came out that was kind of threatening its use, all of our 340B benefits are used for our patient benefits directly for our uninsured patients. Definitely our books are clean on that regard. This is one of our sites. And I put that orange thing there, dream finally coming true. One, because this actually was a dream dating way back when I was still with St. Luke's, of having one health center that offered all of our services into one site. But also because this was a grant that NHCLV got in 2015, and it took until 2020 for us to actually be able to make it come true in the midst of COVID. And so because of building rigmaroles and stuff like that, but we actually, this site is functional in the old ShoreFit factory, and it offers our integrated physical and behavioral health services. And then we're literally about to open right next door to it, our dental and pharmacy within the next month or so. So it offers everything right there on Broad Street. And the beauty of this one is, when we designed it, the purpose of putting it where it was so that it would be only at most one transfer away from anybody in the valley. Since we know transportation has always been a major concern here, I wanted to find a site where almost anyone in the valley, if they needed to come by bus, would only have to transfer at most once. If not, they could just get on the bus and get here. Recent Lanta changes might alter that, but I did get a promise from them that they would change that if need to. So these are our 4 sites. Casa is being renovated, so our 218 is getting upgraded right now, but we actually do have 5 sites. We have the site in the Casa Guadalupe site, South Side Bethlehem, that's the school-based site in Donegan, the North Side site, and then in the Two Rivers building in Easton. All the sites are integrated. They don't all have dental. We don't do substance use disorder in the Donegan site, obviously, because it's a school-based site, but they do all offer physical health, integrated behavioral health, and they do offer the behavioral health with a psych NP as well, besides the counselors. This is an example of Broad Street just when it was first done with construction. They all kind of focus on patient-centered medical home or team-based care. So this was just when we were setting it up for the COVID care. And this was Hamilton under construction. This site is 15,000 square feet, and again, focused on team-based care. These are the services that we offer. We have the full gamut, including neighbor to neighbor or time banking, and where patients are volunteering their time, or community serving community. We do have a contract pharmacy that serves our patients and will deliver the meds to them at home. 70% of our patients have English as a second language. So predominantly all of our frontline staff do speak Spanish. 91% of our patients are Latino. We do offer refugee care. Right now, the predominant refugee population that we're serving are coming from Ukraine. So we do still offer that service, and we do tend to keep those patients on after we've provided the service and started. We still offer women's health care and prenatal care with a contract through Maternal Family, but also we do low risk prenatal care, and in partnership with Veronica's health center clinic, we do see a lot of patients, and they do then follow up over there. And we offer wraparound social services for SUD. We were one of the first sites for substance use disorder for medication assisted therapy. So we are their primary care medical home, as well as where they receive that integrated behavioral health. You know, it's a co-occurring disorder, right? So we don't offer them the drug treatment. We refer that out. But we do and can offer them all the other services under one roof, which is similar, you know, to St. Luke's and Lehigh Valley. But that is a program that we've had. We provide care for close to 300 patients in that program. That's been one of the longest standing. We've had that program since 2017. So that's been there. This is an example of, again, quality. All health centers are held to very high quality expectations. This one is a dated one from 2020, but still our measures, we're usually in the first quartile for prenatal care, early entry, prenatal patients, and low in birth weight. One thing that's interesting is we have to follow our patients even if they don't stay with us through birth. So let's say they come to us in the first quarter, in the first trimester, but they then go over to the women's clinic. They expect us to continue following our patients till after the baby's born to make sure that everything worked out okay. So that is an expectation for health centers. So we make every possible attempt to follow all of our patients. We usually follow about 140 women, pregnant women a year. And up until last year, or 18 months ago, we actually had an FMOB, so a family medicine doc that actually was still delivering in the hospital. For a little while, she was the only one left, but she's since retired. These are a sample of our partners. Obviously, you know, we partner very similarly. We were during COVID, we were filling in the blanks for public health. And I say that because no public health department likes when a community health center steps all over them. In some of the more rural areas in the state, community health centers were definitely taking the forefront because, you know, the state of Pennsylvania's community health or public health department is very, you know, not very robust in some areas in the state, but we definitely were filling in the blanks. So if they called upon us to go to the homeless shelters, go to the, you know, the soup kitchens, we did home-based COVID vaccinations with the AARP and Lehigh County, not AARP, excuse me, Area Agency on Aging. We worked with them. We did Northampton County, all up into the rural areas. We did home-based COVID vaccinations. You know, we did big COVID clinics with the YMCA in some of the other areas in the high rises in Northampton County as well, and school-based ones for families and kids. So we did those kinds of things. We did some of the private parochial schools and charter schools. So we didn't do big flashy things. We did more of the filling in the blanks whenever they needed us to. We remained open. We didn't have to close any of our doors, but we weren't particularly well staffed all the time. So I'm being a nurse, I would go out with some of my other nurses and we would help fill in the blanks. So that's how we worked. I welcome you to visit our social media. We do have some interviews from some of the original founding members, as well as some of our patient board members. I don't want to bore you with those, but I mean, some of them are really interesting from our original founding board members, but there's also some information on how we partner with like even the Mammo Van from Lehigh Valley to make sure that our patients get access to all the services that they need. And I welcome any questions. Thank you.